This is Dr. Sachin Gupta again, presented with a case of posterior horseshoe fistula. It is the fistula which is crossing bilateral ischiorictal fossa, crossing the puborectalis muscle and reached up to the anorectal junction. When it reaches, this tract reaches up to the anorectal junction with internal opening at 6 o'clock, there is a contracture which is created by this internal opening of this fistulous tract. Why it occurs? What happens sometimes when both the tract, when it is united from left to right and reaches up to the anorectal junction, it creates pressure over the sphincter muscle. That is the main culprit of this disease, number one. Number two is what the fistulogram suggests, number one. So this is a fistulogram of this patient. You can clearly see there are two views. One is AP and another one is lateral view. You can see. Number one is the AP view. You can clearly see. In this picture, you can see there is a horseshoe tract. You can see from this end to this end, and dye is injected from one internal opening, and there is a branch which is extended in the D canal space. This branch you can see. So what will be the approach? Number one, how you can cure this fistulous tract. There are various surgeries which are described in the text or in some books. Number one is fistulectomy. Number two is scoring techniques. Number third is fistulotomy. So all they are presented with sphincter injuries procedures. Whenever there is a sphincter injury, you can clearly see there is always incontinence of stool. So what will be the procedure, perfect procedure, which helps the patient from injury? Number one. So for this fistula, I will plan for number one is tropis. Number one, tropis. Number two is I will do first the fistuloscopy from both the ends of the tract, and I will definitely see the internal opening with fistuloscopy. Number second, is there is any secondary branches in both the tract? Number two. Number three is after tropis, I will do the DLPL, that is distal laser and proximal laser of the tract, followed by curettage. Whenever you decided these three procedures, when you combine these procedures, again there is a chances of recurrence. I have seen many cases when I operate many cases with these three techniques. And what will be the answer then? What we will perform this after this procedure? We'll go for Ksharsutra ligation. Why Ksharsutra ligation? Number one is silicone sitons always does not help in draining of the tract. I have seen two cases in my practice when I put two silicone threads in posterior horseshoe fistula. Again there is a recurrence. So why Ksharsutra? Ksharsutra helps in draining of the remnant tissue which is behind the external and internal sphincter muscle without injuring it. The only protocol is do not allow it for cutting. When you allow it for cutting, there is definitely sphincter loss with Ksharsutra therapy also. You just drain the tract and take out your thread. Again, you can see there is a snugging of the cavities always in the postoperative period. So this will save the sphincters as well as this does not cause incontinence of stool. So this is the case. This case is having two external openings, one at 7 o'clock and one at 5 o'clock, and crosses both the ischioanal fossa and reaches up to the lower part of the rectum by crossing this puborectalis muscle. So now I'll show you how to perform this procedure to save the sphincter of the patient as well as helps in curing of this dreadful disease. This is Dr. Sachin Gupta, Proctology Yog Pit Haridwar. Thank you so much.